Bismillahirrahmanirrahim. Dear class, today we will discuss about the tuberculous peritonitis. In last two lectures we have talked about the acute abdominal conditions like peritonitis in general. Then in last lecture we talked about the complications of peritonitis. Today we will discuss about the tuberculous peritonitis, different presentations of tuberculous peritonitis, what are the sources of origin of this disease, their clinical presentation, differential diagnosis and the treatment, and wherever and whatever the role of surgery is there, what are the indication of surgery in tuberculous peritonitis, and what are the different surgical procedure we can perform. That will be our focus of discussion on today's lecture. I hope all of you are well, staying home, and after a break of week we are going to discuss this topic. Just look at this slide sometime. That's how it looks like. Will remain tuberculous peritonitis. The different forms of tuberculous peritonitis, acute and chronic form. Acute form is rare, chronic is very common. And varieties of tuberculous peritonitis are ascitic form, encysted form, fibrous form, and the purulent form. There are four varieties are the presentations of tuberculous peritonitis. Acute tuberculous peritonitis. Acute onset resembles acute peritonitis leading to urgent laparotomy. And as we showed you in the first slide, when you open up, you see there's a straw color fluid and there's tubercles are present all over the varieties. Like conditions. Peritonitis. It presents with abdominal pain. Most of these symptoms they are vague. Abdominal pain, fever, mostly the evening rise of temperature, loss of weight, loss of appetite, ascites, night sweats, abdominal mass. origin of infection from the four sources: mesenteric lymph nodes, ileocecal tuberculosis, tuberculous biosalpins, and blood-borne infection from the miliary tuberculosis. Ascitic form. This is the most common form of tuberculous peritonitis, and peritoneum is studded with tubercles, and the peritoneal cavity becomes filled with pale straw-colored fluid. Usually insidious onset, loss of energy, facial pallor, loss of weight, abdominal distension. Usually there is no pain. So the look is very specific: vague ill health, malaise, abdominal discomfort associated with alternate diarrhea and constipation, dilated veins along the lower abdominal wall, shifting dullness because of ascites, on palpation the transverse solid mass may be demonstrated, rolled up mentum or rolled up abdomen. Diagnosis is seldom difficult when it occurs in acute form, but when it appears in an adult, in which it has to be differentiated from other forms of ascites, especially from the malignant secondary deposits. In child, positive Montus test with ascites strongly suggests negative test is good evidence against tuberculosis. Laparoscopy is a very useful tool, allowing you to inspect the whole of the peritoneal cavity. Where it appears diagnostic areas of caseation can be biopsied, and histological and microbiological studies can be carried out. Also look at the tuberculous disease elsewhere, especially the salpingitis. Chest X-ray is very important and should be done before laparoscopy or laparotomy. And the final court of appeal, if none of the investigation is conclusive, the final court of appeal is laparotomy. Ascitic form, usually pale yellow, fluid is present, usually clear, rich in lymphocytes. Specific gravity is 1.020 or higher. Even after centrifugation, rarely you can find Mycobacterium tuberculosis found, and its presence can be demonstrated by culture or unipex, and the yield is very low. The treatment is anti-cox therapy, and patient can return home if the general condition is good. Encysted form. Third is encysted form or loculated form, similar to the ascitic form, but one part of the abdominal cavity alone is involved. Localized intra-abdominal swellings so give rise to difficulty in diagnosis again. The differential diagnosis in female is ovarian cyst, in children is mesenteric cyst. Laparotomy is performed and encapsulated collections found. It can be evacuated and abdomen is closed, and the treatment is again anti-cox therapy. Complications are most common recurrent adherence formation leading to intestinal obstruction. Fibrous form, fourth type is fibrous form. It is fibrous or plastic form. This is very dangerous type of tuberculous abdomen in which the thick adhesions are formed, and we call it frozen abdomen somewhere, characterized by production of widespread adhesions which cause coils of the intestine, especially the ileum, to become mated together and distended. Okay, and this lead to subacute obstruction, and these distended coils act as the blind loop and give rise to steatorrhea, wasting, attacks of abdominal pain, and may present with subacute or acute intestinal obstruction. On examination, adherent intestine with omentum attached together with thickened mesentery may give rise to palpable swelling or mass, and is called doughy feeling. Subacute, acute intestinal obstruction, division of band relief obstruction. If the adhesions are accompanied by fibrous strictures of the ileum as well, it is best to excise the affected ball. Most common operation is right hemicolectomy, mean removal of the terminal ileum along with the cecum and ascending colon, and right 1/3 of the transverse colon along with hepatic flexure, and primary anastomosis made between the transverse colon and terminal ileum, mean ileocolic anastomosis. Purulent form is, though it's rare, when secondary to the tuberculous salpingitis, the mass of adherent intestine, omentum, and tuberculous pus is present. Sizable cold abscesses. As you know, the abscess resulting from tuberculosis is called cold abscess. Sizable cold abscesses are often formed pointing on surface, commonly near the umbilicus, or burst into the bowel. The surgical treatment is necessary for evacuation of the cold abscess and for intestinal obstruction. Surgery in this form is really challenging because usually the abdomen is frozen and thick adhesions have been formed. If the fecal fistula are formed, that it may persist because of the distal obstruction, so resection of the involved segment is important. Closure of the fistula must therefore be combined with some form of anastomosis between the segment of the intestine above and an affected area. Prognosis of this variety of tuberculous peritonitis is relatively poor. So this picture resembles shows ileocecal tuberculosis, stricture of the terminal ileum. So know something about the epidemiology of extrapulmonary tuberculosis. Several forms of extrapulmonary tuberculosis lack any of the localizing symptom or the sign. Spontaneous allergy to PPD was noted in 30 to 35% of the patient. No clinical or radiological evidence of pulmonary tuberculosis could be found in up to 1/3 of the patient. Isolated abdominal tuberculosis, unselected autopsy series is 0.02 to 5.1%, higher prevalence in female despite increased pulmonary tuberculosis in male. It is secondary 25% of the cases, 25 to 30% of the cases. So there is coexistent pulmonary tuberculosis in abdominal tuberculosis. In the West, HIV and tuberculosis, before the era of HIV infection, more than 80% confined to the lungs. Extrapulmonary tuberculosis increases with HIV. 40 to 60% of TB in HIV plus patient has extrapulmonary tuberculosis. Incidence and severity of abdominal tuberculosis will increase with HIV epidemic. Pathogenesis, mechanism by which the Mycobacterium tuberculosis reaches the alimentary tract, abdomen is a hematogenous spread, ingestion of the bacilli in the sputum from the active pulmonary tuberculosis, direct spread from the adjacent organs and via the lymph channel from the infected mesenteric lymph nodes. This is a man, Mr. Robert Koch, a German scientist who found out the causative organism and revealed its invention in 1882. That's why disease was named after him, Koch's disease. This is the gram-negative bacilli, Mycobacterium tuberculosis. Peritoneum involvement occurs from the spread from the lymph node, intestinal lesions, tuberculous salpingitis, or directly a blood-borne spread like in biliary tuberculosis. Abdominal lymph nodes, peritoneal tuberculosis may occur without GI involvement in 1/3 of the cases. These pictures clearly depicts and shows the emaciation due to the tuberculosis. Thanks to the availability of ATT and awareness programs, blood tests, all are non-specific findings, usually raise ESR level, positive PPD test, anemia, ADA, hypoalbuminemia. This is PPD test how to perform for the forearm, or it is studied. PPD test positive, more than 1 centimeter circumference, or is measured, measuring the area of induration by vernier caliper. Ascitic fluid examination, straw colored, protein content more than 3 gram per deciliter, lymphocyte more than 70%, and culture in less than 20% of the cases. ADA test, amino hydrolase that converts adenosine to inosine. ADA increased due to the stimulation of T cells by the Mycobacterium. AG, serum ADA more than 54 unit per liter, ascitic fluid ADA more than 36 unit per liter, ascitic fluid more than. Connection with HIV, normal or low ADA. Management, whatsoever the surgical procedure you adapt, the treatment of tuberculosis remains mainstay of the tuberculosis treatment remains anti-tubercular drugs. Whatsoever the disease, wheresoever the disease is, either is a pulmonary tuberculosis or extrapulmonary tuberculosis. So the actual treatment is anti-tubercular therapy. So multi-drug combination therapy is started. Usually we start with 4-drug regimen, and these 4 drugs are mostly INH, rifampicin, PZA or parazinamide or ethambutol. These are called first-line tuberculosis drugs, along with the surgical treatment wherever it is needed and whatsoever. That's what we have been talking. So sometimes we need just drainage of pus, just we take biopsies. Sometimes we just, the role of surgery is only to confirm the disease, take biopsies, draw straw color fluid. Sometimes we need to drain the cold abscesses. Sometimes we need to do adenolysis, and sometimes we need to resect the involved segment. And common operation we do in tuberculosis, abdominal tuberculosis, is right hemicolectomy. But sometimes we need to do stichioplasty, segmental resection, and sometimes adenolysis. So any surgery you perform, even you excise the whole organ, but the mainstay of the treatment remain anti-tubercular drugs. So we talk what are the 4-drug regimen: INH, rifampicin, PZA, ethambutol. You start with 4 drugs for 3 months. After 3 months, you switch off PZA, parazinamide, and then continue with the rest of the 3 drugs for another 9 months. As the most of the regimen for the pulmonary tuberculosis are now for the reduced period, 6 months, maximum 9 months. But in all extrapulmonary tuberculosis disease, treatment with drugs should be extended to the minimum 1 year, or maybe for the other form of extrapulmonary tuberculosis like skeletal tuberculosis, it may be extended up to 18 months to 24 months. At least 6 months, including 2 months of rifampicin. However, the practice and the treatment often given for 12 to 18 months. Obstetric lesion may relieve with medicine alone. However, most of the lesions which are obstructing the intestine, subacute section, ultimately may need surgery, because most of these strictures, most of these adhesions, they heal with some of the scarring or fibrosis, and can lead to stricture formation of the gut and adhesion formation. They will need surgery at some stage, and what different surgery are performed we have talked just before. Thank you very much for your patient listening, and the question and answer session and assignment session will be once you have listened, complete your lectures, and next time we will start a new topic. So just want to conclude once more. We have talked peritoneal diseases in 4 lectures: acute abdomen, acute peritonitis, the complications of peritonitis, and then tuberculous peritonitis. Thank you very much.